Good evening, everyone. Welcome. Thank you so much for joining us for this virtual UMiami Health Talk, Transforming Lung Cancer Care from Screening to Surgery. I'm health journalist Ileana Bravo, and I'm going to be your moderator for tonight's webinar presented by Sylvester Comprehensive Cancer Center, the only NCI designated and nationally ranked cancer center in South Florida, and its only university-based comprehensive cancer center. Sylvester is home to an expert team of more than 2,400 physicians, researchers, and staff who work together to discover, develop, and deliver world-class cancer care. U.S. News & World Report ranked Sylvester among the best cancer centers in the nation this year. Our hospital earned high-performing ratings for 11 years of care, including lung cancer surgery. And of course, we invite you to learn more about us at sylvester.org. Well, tonight we're privileged to hear from two esteemed Sylvester Comprehensive Cancer Center experts, Dr. Estelamari Rodriguez and Dr. Nestor Villamizar. They will discuss important topics related to lung cancer, including current screening guidelines, management of lung cancer, and surgery. Now, please note that there's going to be a Q&A session at the end of the presentation to answer your questions. It's a special privilege for you. Some of you have submitted them in advance, but there's plenty of time to enter questions during the presentation. You do it using the anonymous Q&A feature at the bottom of your Zoom screen. Take a look at your screen right now, whatever device you're on, locate that little button for Q&A so you can enter them. And we will prepare them for Dr. Rodriguez and Dr. Villamizar to address at the end of the presentation. Well, now it's my pleasure to introduce our first speaker, Dr. Estelamari Rodriguez, a thoracic oncologist. Dr. Rodriguez is the Associate Director of Community Outreach and co-lead of the Thoracic Site Disease Group at Sylvester. She has a special interest in early phase clinical trials and is an active member of the Experimental Therapeutics Program at Sylvester. She's given numerous lectures as an invited speaker on issues related to lung cancer and healthcare disparities, a very important topic. We welcome Dr. Rodriguez. Make sure you unmute yourself and take it away.
Thank you, Ileana, for that introduction, and thank you for being here today to all our guests. So November is Lung Cancer Awareness Month, and it's very important for us to talk about lung cancer because it's the number one cause of cancer death for both men and women. And we're very invested in finding new treatments for lung cancer. I will start with the good news. I'll put it here. The good news is that lung cancer death rates have been going down. The lung cancer death rates have been going down, and we can attribute that to different rates of tobacco, and also to screening for lung cancer to a lesser degree. And we wanted to highlight screening because we want to prevent new cases of lung cancer. So I wanted to discuss lung cancer screening. So we've known for over 10 years that low-dose CT can be used for screening for lung cancer. And this is based on a very large trial where we randomized patients that were high-risk smokers. And they were randomized to 3 yearly CT scans or 3 yearly x-rays. And in that study, we found that if we screen for lung cancer, we can detect lung cancer at a stage where we can cure lung cancer with surgery. And that's what we would like to get to. So the prior guidelines started doing screening at age 55 to 80, and it was really looking for patients that were very high risk with a 30-pack-year smoking history. That is the equivalent of smoking a pack a day for 30 years. So we really only concentrated on a very high-risk group, but we have learned that there's different groups that smoke less and do get lung cancer. So the guidelines have been revised since 2021, and we wanted to highlight that here because if you know someone who's age 50 to 80, who's a current or former smoker and quit in the last 15 years and has had smoke, you have to have smoke so we can find things that are more likely to be lung cancer, but we're looking at a 20-pack-year smoking history. So we're trying to see if we can detect lung cancer early at a stage that we can treat it. And we have a program at the university where we do that through a shared decision visit, smoking cessation counseling, and we arrange for the screening. And the good news is that we have found that by doing these low-dose CT screenings, we can decrease the mortality from lung cancer, and we can decrease the mortality overall. Now, there are some good things and bad things. So people worry that lung cancer screening is going to expose them to unnecessary procedures and that they're Sometimes patients don't want to get lung cancer screening because they don't want to get bad news. So I just wanted to kind of compare lung cancer screening to the very common screening test that gets done routinely, which is a mammogram. And the false positive rate, so meaning how many times we find things on a test that are not cancer, that can be seen both in mammograms and in low-dose CT, but by having this screening test at a place at the University of Miami where we discuss them in a multidisciplinary group, we can really select the patients that really should have biopsies. And the one thing is that we do these tests on a serial basis. So sometimes we initially find a nodule, and then we have specific guidelines where we can follow that nodule over time. So really the false discovery rate that we will is very low. So most of the time that we find something that we believe needs to have surgery, it is a lung cancer. And the false positive biopsy rate for a lung cancer screening program, much less than for a mammogram program. And I think what is very telling when I talk to my patients is how many people we will have to treat, screen to prevent one death. So it's actually much less than mammograms. You actually have to do mammograms in 800 to 900 women to identify one patient that will be safe from breast cancer by screening. And that is a third of that would be the case for lung cancer screening. And another question that we get is about the source of radiation. Do we get too much radiation by doing these CAT scans instead of X-rays? And as I can show you, it's a slightly more radiation than mammograms, but it's definitely in the range that is safe for patients and below the average background radiation that patients are exposed when they travel and just basically living around. And what is really important is that this is a low dose CT. So really a seventh of the dose of radiation that you will get in a routine diagnostic CT. Now, the bad news about screening is that we've known about it for 10 years, and still in the country, about 8 to 9% of eligible high-risk smokers get screened. In Florida, it's even less. We're about 3%. So we have a lot of work to do, and we do a lot of research and spend a lot of time. We have a navigator, Dr. Villamizar, will describe our program further, but it's very important that we talk about lung cancer screening, that we discuss it with our primary care physicians, and that patients inform themselves the same way that they women remember to get their mammograms every year, that we really get more patients to get screened in our state. So we wanted to really highlight screening as the first tool for prevention. We know that lung cancer screening finds 80% of lung cancers at an early stage when it's most curable. And Dr. Villamizar, who will speak next, will really talk to about how we can really do this surgery safely now. The lung cancer mortality is reduced by 20% with screening, and the all-cause mortality is reduced by 6%. So basically, patients that enter lung cancer screening have a lot to gain. We can decrease our mortality from lung cancer and other cancers and other causes, because we do get plugged to the medical system, and sometimes we find other things that need to be addressed, like coronary calcifications and other things. This is a process that should be done in a multidisciplinary way and should include shared decision and teachable moment for smoking cessation. And there are other things that we can detect through lung cancer screening that are of interest that we can address. I will stop there and have Dr. Villamizar talk to us about surgery.
Okay, perfect. Thank you. Let me go ahead and introduce Dr. Nestor Villamizar, an associate professor of cardiothoracic surgery at the University of Miami Miller School of Medicine. Dr. Villamizar is also the program director for the cardiothoracic surgery residency and co-director of the lung cancer screening program at Sylvester. He has a particular interest in minimally invasive robotic thoracic surgery, including lung-sparing complex segmentectomy, complex lung resections after induction therapy, and operations for esophageal diseases. Okay, now it's all yours, Dr. Villamizar. Take it away. You have to unmute.
Thank you, Ileana.
Okay.
So the importance of getting a low-dose chest CT is that we can save life by detecting those nodules when they are small. And this graph represents the advantage of getting the surgery when the nodule is still quite small. So each of these lines represents a different size of the tumor. And when they did this study, they had thousands of patients, and then they followed these patients over time. At 5 years, if the cancer was removed when the nodule was less than 1 centimeter, the vast majority of those patients were alive and cured from cancer. Every time that that nodule grows by 1 centimeter, even when the cancer has not traveled to the lymph nodes, the opportunity of being alive 5 years after that diagnosis gets lower. So many times when we detect these nodules in our lung cancer screening program, then the patients meet with me and I'm constantly pushing them to have the operation sooner rather than later. And this is the reason. We know that size matters, and the faster that we can remove that cancer, the better the chances of being cured. Now, our lung cancer screening program has a very long history that started in 2010. And over the years, we have basically adapted all these new guidelines and the approvals from Medicare and the private insurance company to allow patients to get screened without extra cost. This is a relatively old slide. I think that that was about 2 years ago, but at that time, we had screened 645 patients, and out of those, we detected lung cancer that was operable in 15 patients. 13 of them underwent surgery with a curative intent, and then only 2 out of those patients had the cancer coming back after the operation. And this is very similar to what was reported in that lung cancer trial that Dr. Rodriguez mentioned, that that was the one that approved CT scans as a screening method for lung cancer. So we know that out of all these patients that we are screening, we are going to detect only about 2% of them that are gonna require any surgical intervention. And what I don't wanna ever see again is this patient that was treated at a community hospital and probably didn't realize that he had this nodule, in 2017. It was a small little nodule here that probably was not suspicious enough to have, being referred to a thoracic surgeon. And then we realized that in 2018, he gets another CT scan, but because he was not part of a screening program, then they probably didn't report that there was a significant change in size. In 2018, as I showed in my first slide, this patient had a very good chance of cure with a very simple, minimally invasive operation. But then the time passed, and then he gets another CT scan a year later. Well, that cancer has already grown 10 times and has already traveled to the lymph nodes. And the chances of being cured are much less. This was a patient that we still treated because we have the advantage of doing our multidisciplinary approach, and with a combination of chemotherapy and immunotherapy and then surgery, we can still provide a relatively good cure rate of about 50% for patients, but it's not the same as the 80 to 90% when this is early stage disease. So the emphasis here on this lecture that we're giving is that people should get screened if they're eligible, because when we find the cancer early, we can cure the majority of those patients. And now we have the robotic technology that helps us to diagnose these tiny little nodules. They don't have to necessarily go to have an operation for us to have an accurate, precise diagnosis. Now we have robotic bronchoscopy at our hospital, and these small nodules our pulmonologists can reach and give the diagnosis early. And we also have the opportunity to do complex operations that just take very small segments of the lung. In the past, what was called the gold standard operation for lung cancer was to do a lobectomy, remove a large portion of the lung to be able to cure patients and remove all the lymph nodes. But there are studies that have been done in Japan and also in North America that now prove that removing a smaller portion of the lung, as long as you get good margins and good lymph node dissection, then it's equal or even better than removing the entire lobe. And that's what we provide to our patients when the size of those tumors are less than 2 centimeters in size. And we do that using minimally invasive robotic surgery. This illustrates the tiny little holes that we make in between the ribs to place the robotic machine and remove these cancers. This is operating in a computer, managing this, controlling the arms of the robot. And the other thing that differentiates Sylvester, our lung cancer program at Sylvester, is that instead of having this serial model of care in which the patient first gets a CT scan and then gets referred to a pulmonologist and then goes to a medical oncologist, and it's taking like 3 months for the patient to have a diagnosis and treatment, we try to expedite this treatment plan, and we put the patient at the center, and we all providers that treat lung cancer get together and formulate a plan to treat those patients as fast as possible. That's why we created our virtual multidisciplinary clinic, and as you can see, many of us get together to treat complex patients. I think Dr. Rodriguez has some slides about treatment after surgery.
Yes, Dr. Villamizar, I see you concluded this portion. So now let's bring Dr. Rodriguez back in for further discussion on treatment after surgery. And we're going to be taking your questions shortly, so stay with us. I see that many of you have entered some, so please continue to do so. Go ahead, Dr. Rodriguez.
Thank you, Ileana, and thank you, Dr. Villamizar, because I think that really this multidisciplinary care we have seen, it really can change everything for patients. We have patients that come to us that have been told elsewhere that they're not eligible for surgery, and we're able to find options. Obviously, we review the pathology of all the patients that come to our center, so that's also very critical for patients to be part of a multidisciplinary team. Now, the second part, so at the beginning, I started saying that, the good news is that lung cancer death rates are going down, but we have a lot of ways to go in terms of getting more patients to get screened. The second part of the message that we wanted to highlight during Lung Cancer Awareness Month is that lung cancer has really been transformed, not only because we can screen for it and find it earlier, we can treat it better, patients are doing better even when they have advanced disease, but really the face of and the treatment of lung cancer has changed, and I wanted to explain why. So, many patients think of lung cancer as a very heavy smoker, very, very sick elderly patient, but we're seeing younger patients, we're seeing more women, we see patients of every race and ethnicity. So it is important to recognize that lung cancer can affect anyone who has lungs. And after surgery, so if you do get surgery, like Dr. Villamizar explained, and we are able to find the best treatment option for you and resect the cancer, there's still patients that recur after surgery. And what we try to do in the medical oncology side is to try to offer treatments after surgery that are going to improve the outcomes. But up to now, we have been very limited into how much more we can offer patients after surgery. We meet with patients that we think are high risk. And I will tell you these are curves that we use in medicine, but the first red curves are patients that get surgery alone. And when we add chemo, there's really a small improvement, about 5, depending on your stage, between 5 and 14% that the added chemo after surgery can improve your outcomes. And for patients who don't have surgery, which is the blue line on the bottom, there's also a small improvement to chemotherapy. So we've known for a long time that chemo can cause side effects after surgery, and that is limited in terms of how much it moves the needle in terms of survival, but it's everything we had up to this point. But everything changed, and it really has changed in my lifetime, in the time that is since I got in trained, and Dr. Villamizar as well, because the era of targeted therapy and immunotherapy has really been that big bang moment that has really allowed us to find treatment options for patients that were not responding in the past. We have a lot of ways to go, but there are patients alive today because of this, of all the development and understanding the genes that trigger cancer, and we have new options for those patients. And all of those options have been currently available for patients that have advanced cancer. So we know that patients that have advanced cancer can get tested for what is called biomarker testing. So looking for the drivers of that cancer in the tumor so that we can try to target what's causing the cancer. And immunotherapy is a very novel way of treating cancer that uses your own immune system and causes less side effects, especially for older patients. So all of those options have been there for metastatic disease in the last 5 to 6 years. But now we're moving those options for patients that had surgery, and we're hoping that that's going to really move the needle in terms of what we're able to offer patients after surgery. So one message that I want to kind of leave with you is that if you have lung cancer and it's advanced, you need to have next generation sequencing, which is really, you need to have the tumor analyzed so that we can understand that tumor, because we used to think that it was just like smoker's disease and all the lung cancers were the same and they all needed chemo, but that's not the case. There's actually lung cancers that are driven by specific mutations. So I will highlight one of the most common mutations are called EGFR mutations that we've known about for almost a decade. And initially we didn't know what was in this mutation that we could do better, but eventually we understood the receptor and have now 3 or 4 generations of pills that can target this receptor. So very important to recognize this mutation and look for it. There are other mutations that are very rare, but lung cancer is so common worldwide that these are actually, when we look worldwide, how many patients have HER2 mutations is a large group. I have patients with all of these mutations in my practice. And in the last year, we have identified a treatment option for the biggest group, which is this KRAS aggressive disease of mutation that is usually resistant to chemotherapy. So 13% of those have a specific KRAS mutation that now we have an option. The other thing I will tell you that this science is moving really, really fast. So when patients come to us and they tell me, how am I going to do? I actually, truthfully, it's hard to answer that question because we have treatments today that were not available before COVID, which is only 2 years ago. So the science is moving really fast, and that's why it's important to get opinions from other doctors to really dig in and look at the cancer and understand how we can treat it better. That's what we call precision medicine, when we understand. And now we know about over half of the patients will have mutations, and 10 of those already have FDA approved drugs in metastatic disease. Now, how do we move this development forward? So we know that we first have to get the drugs approved, and a lot has happened in lung cancer. So over the last 10 years, all these little dots here are new pills for lung cancer that have been approved. The excess here are the chemotherapies that have been approved, but we're really moving away from chemotherapy in lung cancer, trying to find the immunotherapy options. And we now have 5 or 6 immunotherapy options in metastatic disease in lung cancer. And we have multiple pills that are really treating these target mutations. And I will highlight that in the last year, we actually have moved some of those treatment options for patients that had early stage lung cancer. So one of the things I want to highlight is that we can use immunotherapy now since October 2021 after surgery for patients that have stage 2 and 3 and have lymph nodes involved, because we think they are higher risk, and we can add immunotherapy after surgery. And then now in the last year, and we've been doing it longer at Sylvester, we're trying to use immunotherapy because we know it can work. We're trying to use it before surgery to really get results, and I will show you those results. So let me go back. So I just wanted to again highlight lung cancer the face of lung cancer has changed. The rates of lung cancer also are rising among never smokers. So if you have symptoms of cough or shortness of breath, these are things that you have to bring up to your doctor, because we are seeing younger patients who have either never smoked or smoked very little. So in the United States, 7% of men and 20% of women are never smokers that have lung cancer. And women account for 2/3 of all the never smokers who develop lung cancer. So fortunately, we are learning about why that is happening and understanding those genetic changes that develop. So one of the more common ones are EGFR, but there's several other mutations that are important to find when you find a never smoker with lung cancer. Now, shifting to the treatment of immunotherapy before surgery. So I just wanted to show you these two graphs, and it's really showing you patients that we have seen this, and we really been very impressed by patients that had large tumors that we thought we couldn't do surgery on, and we give those patients 3 treatments of chemotherapy and immunotherapy. So on the left, you see what happens with it's called the pathologic complete response, where we actually do the surgery and find no cancer. And that happens in about 1/4 of those patients that get chemoimmunotherapy before surgery. Now, when they get chemo alone, that rate is very low, only about 2%. So it really tells you that there's a 10-fold increase in the response of that tumor and getting patients to a better surgical outcome when you can offer this chemotherapy and immunotherapy before surgery. And we're proud to say that we were part of this registration trial, because we get offered those trials and we were able to enroll patients on the trial. Unfortunately, that drug is now available for every patient in the last year, since March of this year. And then major pathologic responses are seen in about 37% of patients. So this is something that we believe on, and when we discuss these cases together, we talk about it. The other thing that we believe in is really doing biomarker testing on these patients in all our patients that have lung cancer, so we can find better treatment options. And this is another curve of another treatment option after surgery for that select group of about 15 to 17% of patients that have a mutation called EGFR, we had mentioned earlier. We have known about that mutation for a long time in the metastatic setting, but now we have data that we can really change the outcomes of patients after surgery that have this mutation. So in the past, we were giving patients chemo, and that's the yellow curve. A lot of them will recur in the first, second, and third year, and a lot of them will get brain metastases because these cancers can progress and be aggressive. And when we gave patients this pill, and we've been doing this over 2 years now, we are seeing that patients are less likely to progress. So they're on the top with 97% survival at a year, 90% survival at 2 years, and 80%. So a very dramatic, we never really see in medicine these big curves that divide. That tells you there's almost like an 80% improvement in survival by just doing this pill. So what is important to recognize that if you don't really get evaluated for this biomarker, then you will never have this option, because if you had surgery at a place that really didn't dig in more and didn't look for these mutations, then you will be followed every 6 months and you miss the opportunity of getting a better outcome. So that's really important for us to recognize. And I think what I wanted to kind of end with and really get a lot of more questions from the group is really just to show you that there's a lot of hope in lung cancer. When I was a fellow, and I'm not that old, the only things we really had to offer patients were chemotherapy. And I'm just showing you an image of Brickell Avenue in Miami when on the 80s, late 80s, early 90s. And this is how it looked. It was empty. The buildings were old. We really didn't have a lot of excitement going on in that neighborhood. And that's how lung cancer was. Patients will come to us, and some patients will be sent straight to hospice because they were not candidates for chemotherapy. And at that point, when I was a fellow, the first drug, erlotinib, that was for this EGFR mutation was discovered in the United States. And there was a trial in Canada called the BR21 trial that they offered it to every patient with lung cancer that had advanced cancer. And they didn't know who would respond because we were not testing the tumors in the patients. But we know that about 15 to 20%, at that point, it was like Asian women, never smokers, more likely to respond. But obviously now we know why. There were patients that had this driver mutation, that they were not born with these mutations, but these are the drivers of their tumor, and this is what stops it. So this is why I had to offer to patients when I finished fellowship and forward Brickell Avenue, more expensive, but really more interesting, because we really have more to offer patients. We have all of these options that relate to using your own immune system to attack the cancer, which is in a way the most targeted treatment that you can have, where your own body recognizes those abnormal cells. And what is the promise of immunotherapy for early stage cancer and later stage cancer is that once you build an immune response, almost like a vaccine, you know, your body knows that it can react, that cell is abnormal. And that's why we have seen, even in metastatic disease, and now we have 5 and 7 year survival of those trials of immunotherapy, that patients are alive and surviving cancer. Patients that I have treated that had brain metastases, that with their immune system being activated, all the cancer went away and they're off treatment. So we never have patients with metastatic disease that were off treatment. And we hope that adding that immunotherapy now in the earlier stage of disease, we can get better responses than we used to get with chemo alone. And that hopefully a group of those patients, we know that those are the patients that have the more sensitivity to immunotherapy, have this more receptors for the medication called PD-L1. So when you talk to your doctors, if you have lung cancer, they should be looking at all the genes and the PD-L1 receptor for immunotherapy, because that will really drive our decisions for what to offer patients after surgery and when the cancer is advanced. And really the targeted therapy story is just beginning. I don't think there's more space for more buildings in Brickell Avenue, but we definitely have more space for more treatment options for all our patients. And the idea of precision medicine is that almost there could be a treatment for every patient, because every patient is different and all their mutations are different. And these things are dynamic, they change over time. So we have patients that may start with an EGFR mutation and years later develop a resistant pathway where the tumor is trying to go in a different way. So we spend a lot of time trying to test the tumors to understand how they change over time so that we can open other options. And I think my hope, if you tell me how Brickell Avenue will look, I guess we're going to extend into the ocean, and we're going to have new treatment options for almost every mutation in earlier stage disease. The big challenge is that as promising as things look, patients progress after targeted therapy, sometimes after years of treatment that they have responded to. In immunotherapy, there's about 20% of patients in metastatic disease that are cured, but there are many patients that are not. And that's really the challenge. And we have a lot of trials at Sylvester trying to see how we can turn every patient into a patient who responds to immunotherapy. We call this the tumors that are cold, and we need to turn them into hot tumors that stimulate the immune system. So we really have to kind of, we know about the science, we know that it can work for some, now we have to kind of find ways to make it work. Now, these treatment options are for patients that, that I mentioned, the targeted treatments and the immunotherapy are mostly for patients that present with advanced disease. But really, the reason why we're having this webinar is that we want to find patients earlier stage. We want to find patients that Dr. Villamizar can take to surgery, because that's really ultimately the cure for lung cancer, either to prevent it so that we don't even develop it, or to really find it early when we can do surgery for it. So very critical that we get this information out there in terms of screening, that we understand patients that get diagnosed, that we get all the testing done on the tumors, because that is extremely critical for them. So I will end there because I think we have a lot of great questions from the group, and we can take those questions now, Ileana.
Yes, we certainly do. Thank you. And I too remember Brickell in the 80s. It's a whole different city, but I think what's notable about this presentation of hope that you're both presenting is that back in the day, I think when you uttered the word lung cancer, it was like in a whisper, because it was considered a death sentence. And wow, how far have we come, that between immunotherapy and targeted therapy and all these things, that you can literally supercharge the body to fight the disease. So let's start with the first question, because we do have quite a few of them and very good ones. People are listening and paying attention. But the first one that I'm going to ask you that was sent in advance is, how often should you screen if nodules are discovered?
Yeah, I can take that question. So the screening should be done annually. even if you don't have any nodules at all. So for those patients who meet the criteria, meaning older than 50 years old with a 20-pack smoking history and that quit during the last 15 years or are still smoking, they should have a CT scan with low dose every year. Now, when we find the nodules, then they get into an algorithm in which our radiologists tell us if the nodule is suspicious for lung cancer or not. And that depends on the size of the nodules and the characteristics of the nodules. For example, somebody who is a smoker and then we see on the first CT scan a nodule that is less than 4 millimeters in size, the recommendation is going to be to get another CT scan in 1 year. However, if after the first CT scan, they see a nodule that is larger than 8 millimeters, then those patients get referred to my clinic. And the first thing that I do, other than getting the history, making sure that they didn't have cancer elsewhere, that they didn't have an infection or things like that that could explain these nodules, is then to do a CT scan in 3 months, because then I have a way to compare if the nodule is growing. If the nodule is growing, when I do that CT scan at 3 months, then it gets very suspicious because no nodule in the lung should grow in such a short period of time. So that's when we do all the other tests and investigate if the likelihood of being cancer or not, and then we start thinking about biopsies and things like that. That's pretty much the.
Okay. Here's an interesting question then, and I'm going to sort of jump around simply because you're hitting on topics. This is a person who says in 2019 had an incidental finding of 2 nodules, 2 millimeters. The pulmonologist said per the guidelines, because that person's low risk, they didn't need to have another CT scan. And the question is, have the guidelines changed? And I'm hearing you say, yes, indeed, they have 2019, 2021. Should this person have another CAT scan, CT scan now?
So one of the differences is that we have what we have described, which is our lung cancer screening program. And that is for people who meet the criteria that we mentioned. Smokers, 50 to 80 years old, that, have at least a 20-pack year history of smoking. However, many of us get CT scans for many different reasons. And then having nodules in the lung is kind of like having freckles in your skin. The majority of people have nodules in the lung. And not everybody who has freckles is going to develop skin cancer. The same way happens with lung nodules. So the art is to know which of those nodules are really suspicious or not. So those patients that are not smokers or didn't have that 25 year history of smoking, then those nodules are what we call incidental nodules. They were not in a screening program. They had a CT scan for whatever reason, and then they find the nodules. So they don't belong to our lung cancer screening program, but they go to our incidental lung nodule clinic. It's a different kind of program that we have here at Sylvester, in which we kind of figure out as well, depending on the history and all that, when we have to follow up those nodules. So the guidelines that the audience is referring to is what are called the Fleisner guidelines. It's a society that created these guidelines for incidental lung nodules, and then depending on if they were smokers or not smokers, they classify them as a low risk or high risk. Also, if there is a family history of smoking or not, or exposure to asbestos and all other things that they consider high risk. And then they decide how often that patient needs to come back to get another screen. So for a 2 millimeter nodule, it doesn't matter if you are high risk or low risk, there is no need to repeat a CT scan. But If it is larger than 4 millimeters, depending on whether that patient is high or low risk, it will require to repeat a CT scan at 6 months. It's like 3 to 6 months. If it is low risk, then it's 6 to 12 months. It changes, but it's a completely different program.
Got it. Okay. Here's a registrant who says, this is a very interesting one, secondhand smoke. Now we're talking about. This person is asthmatic. Father died of lung cancer. Asthma worsened in the last few years, was exposed to secondhand smoke, 4 to 5 packs a day among the family. Should this person also now be screened as a secondhand smoke?
So sorry that I'm taking all these questions,
No,
but
no,
this
these
is
are
kind
great.
of
These are great.
in my area of expertise. So there are no guidelines for secondhand smoking. So they don't meet lung cancer screening criteria by what is approved by the private insurance and Medicare. However, by the National Cancer Comprehensive Guidelines, some of those patients, if you start adding risk like family history, secondhand smoking, and all that, then we know that they are at a higher risk than somebody who didn't have the history. So at Sylvester, we offer a low dose chest CT for those patients. Now, that probably is not going to be covered by the insurance because it's not meeting the criteria, but it can be paid out of pocket. And I'm not sure what the cost is now. I know it used to be like $140 or something like that, but definitely I think at the end we're going to have information with phone numbers and emails and things like that, that the audience can find those answers.
Indeed, we are. And appointment and all of that. Dr. Rodriguez, you want to weigh in on that? Because I have a perfect one.
No, I mean, we can answer the next way, but I did wanted to add to that, this is going to change. I was talking in my discussion about never smokers that get lung cancer. So there was a large trial in Asia where this happens more often in the United States, that they looked at screening never smokers that had a family history, and they found a detection rate about around 2%, so that you can find never smoker groups that are high risk. And we just don't understand all of the genetics of that or the environmental factors that play into that. But it is an evolving story. And I think that if you have a strong family history, like Dr. Villamizar mentioned, you should talk to your doctor about at least one initial image scan.
Okay, so here's the question that you just touched upon it. Biomarkers for lung cancers, are there?
Yeah, so really critical. I mean, in 2022, going to 2023, if you are a patient with lung cancer, definitely with advanced lung cancer, your options will be very limited if you don't do biomarker testing. So for you to have the best treatment up front, you should be tested. We know that patients that get this test later on in their course don't do as well as the patients that get this information from the get-go. We also know there's a lot of disparities in terms of testing, so that in the whole country, only about half of the patients with advanced lung cancer get tested before their first treatment. So really important for people to educate themselves and kind of push for that. Insurance companies will cover it for metastatic disease. For early stage disease, they're starting to cover it. And we have seen it covered, but the only 2 tests that you really need right now for early stage disease is PD-L1, which is a very cheap test that we do in-house with our biopsies, and then an EGFR test of a specific gene mutation. So those are the only 2 options that we have today. But as I tell you, I predict that this is really going to evolve. Many of our patients, we are favoring that we get the whole testing from the beginning.
A question that passed my mind is, what's the difference between CT scan and PET scan, this person asks? And should one be the one specifically applied for looking for lung cancer nodules?
I will let Dr. Villamizar, because he uses this for his planning.
Yeah, so the CT scan and a low dose is basically just like a picture of the lungs. It's like a very advanced X-ray, in other words. And that's what we use for screening. Now, if we find a suspicious nodule, especially the one that is growing, for example, then we are going to get a PET CT scan. And the PET is a different kind of image because instead of focusing on, kind of like the anatomy, it focused more in like the metabolic activity. So it tells like which sites in the body are metabolically active. And it doesn't mean that whatever is active is cancer. Sometimes inflammation, infection, or cancer can be the same result on the PET. But the PET is a study that we use for staging. Once we think the patient has lung cancer or we have a biopsy-proven cancer, the PET helps us understand if the cancer has already traveled to other places. That is the importance of the PET. It's not a screening study, it's a staging study.
We
I
all
will
learn.
add to that. Yeah, I'm sorry. I would add to that because we get this a lot from patients that already were treated for lung cancer and were being followed. And they ask us why we don't do PET scans. And PET scans, like we mentioned, they're good for the first initial staging. But when you're getting a follow-up after surgery, the CAT scans have more detailed cuts through the lung, and they are the favorite test. Sometimes PET scans, if you have inflammation, will light up in areas, and it kind of really makes you do other extra tests that you didn't need. So for the follow-up, we favor CAT scans.
Got it. And our expert team here that we're so lucky to have at UHealth gives me information here that lung cancer screening is covered 100% by Medicare and private insurers if you're eligible as per the current guidelines, as you said. If you're eligible and do not have insurance, a discounted fee of $99 for the screening may be offered at Sylvester. So that's good to know for those people listening in tonight. Now, how long does it take for lung cancer to go from stage 1 to stage 4, to your point about early detection?
Yeah, that's one question that I get a lot, when I see the lung masses and then the patients want to know how long it took, But the reality is that we don't know because each person and each cancer is different. And that's why it is important for patients to understand that we cannot predict like the growth rate of these cancers. So the earlier that we can get them out, the better. For example, now with like the holidays coming, everyone wants to spend time with the family and the holidays and all that. So of course they ask me, can I wait until January? And my answer is, I wouldn't recommend it. You have to balance being with your family on the holidays and letting the cancer grow while you're spending those holidays versus just taking it out now and maybe not being, those traveling those days. And the reality is that I don't know. It may be a cancer that is not going to grow for the next month, but it could be one very aggressive that is going to go to the lymph nodes. So the answer is always just get it out as soon as possible.
Yeah. And I think this is also to the point of genetics that Dr. Rodriguez is talking about, because why are more women being diagnosed with lung cancer? Is it because of genetic mutations specifically, or are we still studying?
Well, it's important to define what genetic mutations are. So there are genetic mutations that are called germline, that are passed on from your parents on to your children, and you can pass it to your own children. So these are not the mutations that we have found in lung cancer. We have found somatic mutations that develop after you're an adult or in your development. They're not the genes that you were born with that were mutated. So the somatic mutations, why they're being altered more in women, we don't understand. We actually know there's a lot of variety by country. So for example, Peru has a very high rate of EGFR mutations that we were talking, as high as Vietnam, that has about 50% of adenocarcinomas. So a lot of it has to do with the ethnicity and the risk factors of different groups. I think at the end of the day, it's going to be something in the environment that we haven't defined well. I mean, and people have looked at climate change and pollution as a potential explanation, but I can't tell you that we know today. All we know is that family history can play a role. And if you have obviously a family history of other family members that have had a limited smoking history and get lung cancer, I will really come. And we're starting a program of doing testing in those families at Sylvester.
So besides the, the genes that we're studying and the mutations and so forth, and definitely cigarette smoking, I think that's pretty definitive. But how about asthma? Couple questions on asthma. Can asthma cause lung cancer?
That's a great question, because there is, so there's no direct correlation, but there is an indirect correlation of inflammation. So we know that cancers can grow in different states where patients have a lot of inflammation, like we know diabetics, people with metabolic syndrome, which have like obesity, they can have more cancers in general. So there's a concept of inflammation. Asthma itself doesn't cause generalized lung cancer, but I would think that there are patients that get recurrent pneumonias. We have seen like scar pneumonias that become later cancers of inflammation. That's very rare. But it's important to, if you have symptoms that are not addressed, or if your symptoms are worsening, even if you can attribute them to asthma, that you at least get some imaging to kind of correlate your symptoms with what's there in your lungs.
Mm-hmm. Here's a very specific question. Perhaps this person is in the medical field, but do most lung cancer patients have the anti-Hu antibody?
So that is an interesting question, because that's an antibody that I learned as a fellow that can be found in, it can be produced mostly by small cell lung cancers, which is not the most common lung cancer that we see. And it can trigger a neurologic symptom, like it can affect your nerves. And these are called paraneoplastic syndrome. So they're not very commonly found. Now, we commonly don't look for these antibodies, but they are cancers that your body is trying to fight, and you develop antibodies against them, but it's not commonly seen in the traditional lung cancers.
Mm-hmm. Some of these questions are very specific, and for privacy issues, we have to be very careful to answer them. So I'm going to skirt around them a little bit, but here's one that is, after chemo and radiation, which is the best option without surgery? I think it will all depend on the size of the nodules, et cetera, but do you want to take this?
Yeah, so, we spent a lot of time in our multidisciplinary tumor board. We actually had one this evening, right before this meeting, discussing cases of patients that were going to decide to go to surgery because that's the best option for them, or patients that should get chemoradiation. So when we make that decision, is because we have found that either the patient already has disease in lymph nodes that is going to be difficult to resect, and that the radiation will offer them the best treatment option. So usually after you've been treated with chemoradiation, we offer patients immunotherapy as an option, but very few patients go to surgery from there. I hope that answers the question. I don't know if Dr. Villamizar can talk about that decision of surgery or chemoradiation.
Do you want to weigh in, Dr. Villamizar?
Yes, when we discuss those patients at the tumor board, typically we're looking at the images and figuring out how much we need to remove to make those patients curable. Basically, when we plan an operation, the idea is to remove all the cancer that we see. Sometimes that requires to remove the entire lung, and not every patient can have that operation because they don't have the lung capacity to live with the lung that remains. So those are patients that we say are unresectable, not cured by surgery. So that's when we bring our colleagues, the radiation oncologists, to try to offer another curative intent treatment in combination with the chemotherapy. Mm-hmm. If I understand the question correctly, is a patient that had chemo and radiation and could not have the operation, what is the treatment of choice after that? And as Dr. Rodriguez said, we favor the immunotherapy after that, unless there is, again, a mutation or something that is driving that tumor. So then the other therapies, the target therapies, would be available.
Okay. And here's one that I also want to ask real quickly, because for smokers, and that's what we're really talking about, if there's a smoker that has emphysema or COPD, the lungs are already damaged, right? So you have a fibrotic lung or whatever you have that's got the damage in there. Can that evolve to lung cancer? No. One
Usually
thing has
no.
nothing to do with the other.
Yeah.
Okay.
Yeah.
All right, then the final question, which I think we're running out of time because these are so great from everyone, is COVID. Can having COVID be linked to lung cancer? And I know COVID is so young in our world that maybe, do we know?
I'll let Dr.
I don't know.
Villamizar take that one.
Yeah, no, I really don't know. I don't know. And then I guess, as you said, in the future, we may find, that part of the patient history is that they were exposed to COVID, but it's going to be hard to really associate that unless we have like huge studies, in the future that could associate. Now, anecdotally, what I have seen is patients that had a stable lung nodules that were being followed, and maybe with a very small, interval increase in size, that tell me I got COVID. Then there is a CT scan, 3 months later, and then the nodule now is 10 times larger. That I have seen, but was it related to COVID or not? Hard to tell. Possible, yes, because if again, it's all a matter of like how your immune system is controlling the cancer. If your immune system is now, trying to control COVID, then it may leave an opportunity for that cancer to start growing. That's possible, but I haven't seen any clear evidence in the medical literature that that's really the case.
I would be guessing it's going to be studied over the next several years. This is fascinating, and I'm sure that the audience is, hanging to every word. So I would ask for each of you to give us a concluding statement for tonight, one for hope in the future and what we are doing at UHealth Sylvester that is making such a difference in lung cancer. Go ahead. You can start, Dr. Rodriguez.
Thank you, Ileana. So, the best patient is the most informed patient. So I think that you being here tonight and listening and asking questions and really feeling comfortable to do that. We want all our patients to be educated and really understand their cancer and to really advocate for themselves. So like I mentioned, in 2022, going to 2023, if you have advanced lung cancer, you need biomarker testing as part of your treatment. You should get your pathology reviewed. You should really have an expert group and a multidisciplinary group look at your case to make sure that every option was considered. And there is a lot of hope. Lung cancer has changed. We are unfortunately diagnosing younger patients, and we need to understand why. But most patients with lung cancer have been exposed to tobacco. Most of them are age 65 or older. And we have found better treatment options. So I think there's a lot of promise going forward. And it's very important that you understand your symptoms and seek care.
Dr. Villamizar, some concluding comments from you.
Yeah, I think that all of us here tonight should do a better job making this lung cancer awareness. It's very common that women get mammograms, as Dr. Rodriguez said. There is a lot of advertisement, like all, TV, and everybody knows about the pink ribbon and all that. And then we know that lung cancer kills more people than breast cancer. And still, we're only doing 3% of this very simple imaging study that could save tons of life. So, many patients ask me about the vaccine against lung cancer and all these other things that are for, people who are in like a stage 4 advanced lung cancer. When we know that the best way to save more life is to get screened, get detected when the cancer is in an earlier stage, and be cured by minimally invasive surgery. So we need to somehow, if you know somebody who meets the criteria, who has smoked, just ask, hey, by the way, I was in this talk the other day. Have you ever had a CT scan of your chest? And encourage those people to go to a place like our center where they can have multiple options if we discover that they actually do have lung cancer, and they can get treated, they can get cured, they can get a better quality of life, many more years of life. The sooner they do it, the better.
Thank you both so very much. And what a perfect time during the holidays to give your family this gift of life. Go get tested if you're in the high risk group. Thank you both. And here on your screen, you're going to see how to contact our experts at Sylvester Comprehensive Cancer Center. For screenings, it's sylvester.org/lung screening, or call 305-689-5864. For appointments, because I said so many of you had personal information, I really encourage you to reach out to our experts and visit, again, sylvester.org, or call 1-844-324-HOPE. Thank you both, Dr. Rodriguez, Dr. Villamizar. The generosity of your time has been incredible. This webinar is going to be available afterwards for all you registrants, so you're going to get a link to see it later. And thanks for the interactive audience that we had tonight. Thank you both for helping us save lives tonight. So you all have a good night, and please fill out the survey afterwards to give us some feedback on your experience. Good night, everyone. Be safe.